Welcome back to our third session of today. This session is all about the carbon footprint of medicines and how we can improve sustainability across the medicine life cycle for better health. In a minute, we're going to hear a bit from a case study from Canada about empowering patient choices when it comes to sustainability in medicine. But first, we're going to hear from Associate Professor Alpna Mehr with sustainability in medicines and how it needs to be a global priority.
Hello everybody, I'm Alpna Mehr and I'm delighted to be with you today to talk about sustainability in medicines as a global priority. We know that the population across the globe is ageing, and from this chart you can see that from 2015, which is shown on your left hand side, to 2050 on your right hand side, you can see how the population over the age of 65 will increase. Now, this is a positive news story in terms of the effects of pharmaceutical public health, that we have survival at a younger age, but also we have got better in managing non-communicable diseases. However, what that tends to mean is that as people get older, they tend to have more long-term illnesses. So you can see from this diagram that you don't actually have to be very old to be living with more than 2 or more long-term conditions. And this can also be affected by deprivation. So those in more deprived communities, even in countries that are quite wealthy, they will see multimorbidity occurring 10 to 15 years earlier in the more deprived populations. What that means is that in order to manage these multiple long-term conditions, people will end up taking many medications, and this term is often referred to as polypharmacy. The research now suggests that we shouldn't be putting a number on polypharmacy, although in research it is often defined as 5 or more medicines, but rather we should think about, is the medicines appropriate for the individual? So that means that when they're prescribed, all the medicines will help achieve the specific objective for which they were prescribed, and the patient agrees with that intervention. What we really want to address is where it's inappropriate. This is where more than 1 or more medicines are given to the individual that are no longer needed, or the individual is not going to be able to take it in a way that they're going to get benefit. So for example, somebody that has recently had a heart attack may easily take between 10 and 13 medications. And this is what would be referred to as appropriate polypharmacy. However, somebody might be prescribed 2 or 3 medicines, for example, a non-steroidal that causes stomach upset and GI ulceration, and that might be inappropriate even though maybe 1 or 2 medicines have been given alongside. If you look at the chart on the left, you can see that this is data, national data across Scotland. And what we can see here is the number of medicines an individual takes each day. See from here that actually you're not very old before you're taking 7 or 8 different medications. Now you might be taking these 2 or 3 times a day. And that puts a burden on the individual, both in terms of managing their long-term illness, but also in terms of how they deal with adherence. And you can see on the right, medicines that have been returned from one patient. And I've had patients say to me, I'm spending all my day really just trying to navigate my way around the medicines that I'm taking. Now, we know that the more medicines you take, the more likelihood is that you're likely to take a medication that's known as a high-risk medication. So these are medicines, when they're taken inappropriately, are more likely to cause harm. If you look at the diagram on the left-hand side, it's estimated across the UK up to 17% of admissions to hospital are due to medication-related harm. If you take the lower range, that's often given about 11%, and you multiply that data across Europe, This would result in 8.6 million admissions in Europe every year due to adverse events from medications. Now, the stark thing is that this is a public health challenge because 50% of these hospital admissions are preventable, and 70% of these occur in people over the age of 65 taking 5 or more medicines. So we should review people's treatment, but we should also think about the appropriateness of medication when we're initiating treatment for an individual patient. Why is it that people end up on many medications? So if you look at the diagram on the left again, you can see that as well as prescribed medications, individuals will take medicines for themselves, their neighbour might recommend a medication, and many medicines are available over the counter. But we also need to think about traditional medications as well, and herbal preps that have active ingredients. As we get older, our kidney and our liver function will decline, and that will affect how the body handles the medication. And if this is affected, it may mean that we are more prone to side effects. Also, when people have certain illnesses or as they get older, they become more frail. And conversely, the people that become more frail tend to take more medicines, and they tend to be at more risk of medication-related harm. So we need to think about the potential of harm and prioritization of certain groups to make sure we optimize our intervention for these individuals. In order to address this challenge, WHO launched the third Global Patient Safety Challenge, Medication Without Harm. And one of the key flagship areas was medication safety in polypharmacy. And this goes through the background context, which shows that the prevalence of polypharmacy is increasing globally in both developed and developing countries. And I just want to sort of share with you on the right-hand side a rural clinic that I ran in Uganda, just while women were waiting to have procedures done, and really asking them if they were taking multiple medications and they wanted to know more information. Now, in this scenario, many people thought because of deprivation that people wouldn't be able to afford to buy the medication, whereas in fact they were buying multiple medicines and going without food. And it transpired that when you actually sat down and reviewed these medicines were no longer needed. So it has many implications on the burden of the individual as well. So there are many stages where we ought to think about the appropriateness of medication. And if you look at this, it's the prescribing, the transcribing and documenting, the dispensing, the administration and monitoring. Quite often we focus on dispensing and administration, but the most harm to individuals tends to happen at point of prescribing and because we don't monitor. So these are areas that as healthcare professionals, we ought to focus on, but also as patients and the public, they should be aware that they should be asking key questions about what their medicines are for and what their role is in terms of the shared decision-making role of the benefits of medicines long-term. So one way that we can address medication safety and reduce the burden of polypharmacy and make sure that the medication is appropriate is to use a person-centered review, which has alongside it shared decision-making. And one such tool is one that we've developed in Scotland, the 7 steps to appropriate prescribing. And this starts with what matters to you. So making sure that the individual is signed up to the treatment and it's not taken from the total priorities of the healthcare professional. It may be, for example, that rather than taking blood pressure medicines, the individual wants to make changes to their lifestyle. And that might be the first step the individual wants to take rather than taking the medicines. We need to ensure that the right medicine is prescribed, that it has the evidence base within the population that you're going to use it for. Any unnecessary medicines that the individual is taking should be stopped. And then we should monitor for effectiveness and make sure that the person that's being prescribed the treatment is going to benefit from them. We need to ensure that any harmful medicines, any side effects are picked up and dealt with, so that we don't just end up prescribing for a side effect, leading to what we call the prescribing cascade. Importantly, we need to think about sustainability, both in terms of the environment, but also sustainability to the health service in terms of the cost of the medicine to the individual and the health service. We start with the patient and we come back with the patient when we agree and share the plan. So how do we support the individual to take part in shared decision making? And one such tool is the Managed Medicines app. And within this, there's the patient and carer section where they can access and download tools such as cake plots that show them the benefits or harms of different medicines and why they should or should not take these medicines. And these can be used as a point of discussion when coming to a shared decision about medication. Does this methodology work? Well, recently, 6,500 patients across 3 countries were reviewed. And this resulted in improving the appropriateness of medicines in 92% of the reviews and reducing the medicines that individuals were taking by on average 1. Now, the purpose of the reviews is not to deprescribe, although deprescribe may be an outcome, but it's to improve the outcomes of the individual with the medicine. So you can see here the individual says that before my medication review, I suffered badly with heavy legs and wheezing. And after a small few changes, I'm now out walking for 30 minutes every morning. So it's about improving the well-being and the outcomes of an individual. And in 82% of the cases, the interventions were regarded as being clinically significant. So the methodology does work, but it also helps improving outcomes, but also reducing waste and that environmental burden that this can have on the population. And again, here it's just showing you some national data from Scotland, looking at the reduction in the number of medicines on the left, and this is national data, so to try and turn the tide of increasing polypharmacy has been a significant achievement. And then more importantly, if you look at the chart on the right, this is where we've reduced the harmful combinations, the combinations that often drive admissions to hospital nationally over a period of time. What I want to then just reflect on is that we can apply this to all long-term conditions. And if we think about respiratory, we know that admissions to hospital due to asthma are in the region of about 9% across the UK. And quite often these result because of inappropriate use of reliever inhaler rather than the preventative inhaler. Each admission contributes to 500 kilotons of CO2 admissions. And if you extrapolate that figure across the UK, it will result in 32,000 tons of carbon emissions due to just admissions. Now, this is just from asthma, but remember before I said about 11 to 17% of all hospital admissions are due to medication-related harm. So inappropriate use of medicines causes harm to the individual, but it also leaves behind it a carbon footprint, which provides further evidence that we should address this and manage medicines appropriately. It's important that we address the high use of preventative inhalers so that people don't end up going into hospital because they're overusing their reliever inhalers. And just to sort of put it in proportion, this is the size of 1 ton of CO2. So huge amounts of waste due to medication. And the work that we've been trying to do, and that's been done across many European countries, but we've put it into context of the Scottish, is to provide tools for patients to help them understand the carbon footprint of using certain inhaler devices. So whether they use a propellant inhaler, the mileage that this would create compared to a dry powder inhaler and the mileage that would create. And changing from here can have quite a significant effect. And you can see the changes that individuals would need to make to their lifestyles in order to save the same amount of carbon footprint emissions. One of the areas that we're challenged with in the UK is to look at the types of devices we use. And this is equally important when we're thinking about prescribing. So in the UK, we predominantly use propellant type inhalers as opposed to dry powder inhalers compared to Sweden. And in Sweden, they have the lower asthma rates, but they also use dry powder inhalers in approximately 70% for their patients. So it's not that the dry powder inhalers are being done just for the environment and they're going to worsen the outcomes for patients. We can see the evidence shows otherwise. So if we undertake the work of making sure that we have more sustainable choices in prescribing that are focused on patient-based outcomes, we'll get the environmental benefits as well that we need, as well as for improving the benefits for the individual patients. So it's really important that as we think about polypharmacy and we think about different long-term conditions, we focus on reducing the waste that we have from medications. We know that 50 to 80% of patients don't take medicines as prescribed when they're prescribed 4 or more medicines. And this is just, again, waste returned. And many of these inhalers are still full, so they're returned unused. So 1 in 10 medicines in Scotland are incinerated. And we would say that at this point, the horse is bolted. We can't really do much about it. So we want to prevent that waste from occurring. And, you can see the number of car journeys around the world this results in just a small country like Scotland. So if we extrapolate that and we multiply that to being a global situation. Thank you for listening, everybody.
Thanks so much, Alpana. Now, when it comes to the carbon footprint of pharmaceuticals, why is quality use of medicines so important? Well, Dr. Forbes McGain is about to let us in on some insights.
Hello, my name's Forbes McGain. I'm an anaesthetist and intensive care physician at Western Health in Melbourne and Associate Dean in Sustainable Healthcare at the Medicine, Dentistry and Health Sciences faculty of the University of Melbourne. We're going to talk about the carbon footprint of pharmaceuticals. Why is quality use of medicines so important? Well, there's 4 main reasons, and we'll get it over and done with now. For the patient, avoiding low-value treatment. For financial savings. For society, maintaining trust that we're not wasteful in doing unnecessary and ineffective therapies. And for the environment, obviously. And along those lines, we need to ask these questions. Is the medication needed, or are there alternative therapies? So, for example, for the treatment of hypertension, exercise and weight loss for reduction are all important, along with anti-hypertensive medications. And if the medication is needed, how will it be delivered? Importantly, the big difference from both financial and environmental factors, as well as social and benefit for the patient, if you can deliver orally versus intravenously. And for how long is the therapy required? So a good example in intensive care is that we now know that treating ventilator-associated pneumonia for 5 to 7 days is just as effective as treating for 2 weeks. I would disclose that I have grants from the College of Anaesthetists and the National Health and Medical Research Council. I'm an active member of Doctors for the Environment, and I will acknowledge the following folk as well as institutions, including Doctors for the Environment Australia. So for me, this journey towards a more sustainable healthcare system actually started before 2006, but it particularly was an effort of mine from my time with the Royal Flying Doctor Service, when I enjoyed my time immensely there and found it a very rewarding, interesting and useful experience. But at the same time, I realised the enormous amount of effort and financial and environmental that went into looking after patients. You can see here, this is treating a patient close to Uluru. I will also mention that we're going to look a little bit at that intravenous fluid bag you can see in the red box there as we go along when we start talking about the life cycle of morphine. So the bigger picture of carbon healthcare was a study we did with, led by Aranim and Malik and myself from Sydney Uni, looking at what is the carbon footprint of healthcare in Australia. And you can have an approximate study looking at carbon emissions from that. And similarly to other high-income countries like the United States, United Kingdom, France, etc., the Australian healthcare is about 7% of the total carbon footprint of all of Australia. So everything that every Australian does, their travel, their transport, their food, their clothing, all of that, about 7% of that is actually coming from healthcare. So it's quite significant. It's about half of agriculture. Another way of dividing that up is to look at parts of this system. So what I wanted to focus on here is this pie chart, which is the 7%. Pharmaceuticals, and we separated out pharmaceuticals even though they might be used in hospitals and outside of hospitals. We kept it bunched together in the green. You can see there almost 20% of that 7% is actually from pharmaceuticals. So it's actually quite a considerable part of the story. The carbon footprint of pharmaceuticals is big. The other important point is to remember that you can see the pie chart on the left side, which is looking at the carbon footprint of healthcare. That blue, the big blue, is clinical care. In other words, all of the things that clinicians do, all of those things are important, but they're more important in a sense than the grey, which is the energy use directly used by hospitals. On the right-hand side, you can see that this is looking at different levels of care. Effective care is green, and we want to keep that green. We want to greenify it, in other words, reduce its carbon footprint of all effective therapies. But we want to stop low-value care and even the red there with harmful care. And that's where clinicians can have a really important role in just doing less unnecessary care and choosing wisely, for example. A good example of pharmaceuticals, looking at anaesthesia, where I work, 1 hour of desflurane will keep you asleep very nicely, but unfortunately has a high global warming potential. So it's like delivering 2 days of this other medication, sevoflurane, to keep you asleep. So in other words, I'm making a comparison between the two. And that 1 hour of desflurane keeping you asleep is unfortunately the same as about burning 30 litres of petrol. And so you can see a day of anaesthesia with desflurane can be quite problematic. You end up effectively driving your car well more than 1,000 kilometres. Nitrous oxide, or laughing gas, is also a problem. Other fluorocarbons also are greenhouse gases, and a good example is our puffers. So your Ventolin or salbutamol puffer, a metered dose inhaler, 1 puff of that will be like driving an average car 1 kilometre. So it actually becomes quite important. And so ordering dry powder inhalers, as we see in this chart here, changing from metered dose inhaler to a dry powder inhaler is similar to moving from a meat-based diet to a plant-based diet. So you can see here is the metered dose inhaler, and then on the left-hand side, the smaller one, you see much lower is the dry powder inhaler. So where possible, converting from a metered dose inhaler with its propellant gas, which is like the anaesthetic gas, has a high global warming potential, then that is problematic, and moving to dry powder is the way to go. Nitrous oxide we've already mentioned, but we mentioned it here that what we're saying is that by using nitrous oxide for labour or birthing certainly works, but it's not the most effective therapy. And compared to an epidural or other forms of analgesia, when a woman's having a baby, then nitrous oxide has a far greater global warming potential, and it's like driving, your 4-hour delivery of a baby using nitrous oxide would be like driving well more than 1,000 kilometres. We also have done some work looking at these gases, and this pertains to medications. Moving along, there's a large amount of waste of nitrous oxide leaking before the gas is even used, and we've done good work, as have others in this field, in trying to reduce the amount of leaking of nitrous oxide. So life cycle assessment is the cradle to grave. Coca-Cola is the first commercial life cycle assessment way back in 1969, and there are standards that we use for that. This cartoon is basically saying that when you want to analyse the carbon footprint of something, you need to start from material extraction, manufacturing, packaging and product use through to end-of-life care. So it's the whole story. For drugs, this has been looked at for a while from the Sustainable Development Unit in the UK, but the actual details of that, there have been few life cycles really done that are publicly available. Certainly, pharmaceutical companies are doing this, but it is commercial in confidence a lot of the time. A good work from looking at 20 common anaesthetic agents, not the gases we're talking about, but now medications, was done by Pavatka, Eckelman and Sherman and the rest. And they were able to look at, to estimate what was being used by looking at the repositories online of different chemicals to see what their carbon footprint was. So not able to directly work with companies to obtain the data, but at least able to provide a solid evidence base for what was going on. So, as I said, with pharmaceuticals, there are a number of challenges. Data is hidden, or data are hidden, and it's many in-house. We can estimate, as I mentioned, from the 20, for example, the 20 anaesthetic agents. We started morphine. Morphine's important because, in fact, the opium poppy, more than 50% of the world's legal use of morphine, buprenorphine, oxycodone, and codeine actually comes originally from Tasmania. This is the study. This came out a few years ago now, and I take my hat off to the team that were involved. Scott McAllister leading with me, as well as the rest of the group there. So what we were looking at was an intravenous morphine, 100 milligrams, which we use as a patient-controlled analgesia preparation. You can see here Karen Hapgood and Nicole, as well as Scott from Monash University and Scott Melbourne, Elise Neff from Sun Pharma, originally with GSK, as well as the Baxter team who prepare the intravenous fluid at the end, really helping a real collaborative effort. So where did we go? Well, we started with the story of Papaver somniferum, or in other words, the opium poppy, the fields of Tasmania. We looked at the harvesting. As you can imagine, this was a very strategic way of harvesting. The aroma of that emanating from around those tractors is not the same as wheat harvesting. Then you need to look at the pelletizing and all the carbon and other environmental footprints associated with that. This is the bulk pellets, which are from the opium poppy. And then you have the poppy pellets, which you can see here. So it looks like, in a sense, it almost looks like chook feed. And then you move on, and this is the bulk morphine. And you see that white powder, that's morphine, and similarly that bulk buprenorphine, etc. And this is the final product that's coming out of the factory associated with Sun Pharma now. Now, we realised this was not what we use as a clinician, so we needed to move to the next stage, and that was working with Baxter in Toongabbie, Sydney, and looking at salt bags and how we started to prepare the intravenous preparation of morphine, and looking at what was being used there. So you need salt bags, polyvinyl chloride bags to actually contain the fluids, extrusion there. There's the mixing room, as you can see, looking rather like Charlie and the Chocolate Factory. And a really interesting part of the story is, how these products are all brought together to make the morphine with the intravenous sterile fluids and a final product. Now, this is the Baxter manufacturing facility. What I want to just briefly show is this is a classic sort of process diagram in life cycle assessment. The big red on the left, you can see the arrow there. That's showing the packaging is a big part of the story, which was really interesting itself. So the packaging of the drug is very important. The mixing of the carbon footprint stemming from the mixing room was also quite important, although there's not as much. Filling room, as well as the sterilisation. So that was a big part of the story there for what was going on in the final process of manufacturing the morphine. Packaging, really important. Now, the summary here shows you, remember those photos you saw, the bulk morphine coming out of the white powder? That is only about 10% of the total carbon footprint. And what's really interesting, so in poppy farming, you saw there with the tractors. I'll go back there. That's only a small part of the story. And you can see that packaging, sterilisation, a really big part of the story. And so anything that's not the green or the blue is actually everything that's happening in the Sydney factory with Baxter. Very energy intense, lots of sterilisation, and lots of packaging. Moving then to the environmental effects in detail, the carbon dioxide effects from the carbon footprint of morphine is actually relatively small. It's only like driving a few kilometres, that whole 100 milligram bag. And a small of it is actually, part of it is actually coming from bulk morphine manufacturers, we're saying. A lot of it is coming from mixing, filling, and particularly sterilisation. And packaging was very important. In other words, the cardboard and the plastic, not so much the drug itself, not so much the active pharmaceutical ingredient, but everything else that is required to package. That sort of makes sense, though. Even though the manufacture of pharmaceuticals is energy intensive, you're only dealing with micrograms or milligrams in the case of morphine. Whereas when you start dealing with paper and cardboard, you're dealing with masses that are 1,000-fold more in grams and then moving into tens and even hundreds of grams. And so these all add up. But I would say that for most pharmaceuticals, we just don't know. So even though morphine is like that, you've got to remember that morphine is a natural product from those poppies, and that we've got a lot of work to do to make more publicly available medicines' carbon footprints. There's good work underway with the United Kingdom NHS Greening Healthcare under the leadership of Nick Watts and Chris Gormley. So watch this space for what's going on there. But I would say, again, to reiterate, why is quality use of medicine so important? Once again, because medicines have a big environmental footprint, not so for morphine, but we do know overall there's a big environmental footprint going on. All the things you can imagine for the manufacture of vaccines, the biologicals in chemotherapy, many other agents probably have quite different footprints to morphine. And that also it's really important to remember it's the packaging that also is a big part of the story, at least for morphine, and probably likely to be many other drugs, because you imagine the packaging, multiple layers to make them. So it's important for the patient, financial, the society, and the environment. And again, is the medication needed, or are there alternative therapies? If the medication is needed, how will it be delivered? And for how long? I thank very much the National Medicines Symposium team who've invited me to give this presentation. I do hope that you've learned a little bit about the carbon and other environmental footprinting of medicines, realising that we're really just at the beginning of this. There's a lot to be done. There's a lot of work that could be occurring, working with pharmaceutical companies, asking them questions about the environmental footprint of their medicines, as well as work on the level of clinicians to try and consider, now that we're beginning to know that the overall carbon footprint of pharmaceuticals is quite large, how can we as clinicians be as careful as possible in not wasting medications? Thanks for your time.
Thanks so much, Forbes. And now another insight from overseas, this time from Canada. We're going to hear from Dr. Val Stoyanova and Dr. Celia Cully, who are going to discuss the power of patient choices.
Thank you very much for inviting us from Canada. We're here to share our approach to providing climate-conscious care of respiratory diseases. I'm Dr. Celia Cully. I'm a clinical pharmacist in Victoria, Canada, with Dr. Val Stoyanova, internist from Victoria, Canada. We're speaking on behalf of Cascades, which is a knowledge mobilization network, pan-Canadian and funded by our federal government, Environment and Climate Change Canada. We don't have any industry-funded financial disclosures. We are supported through Cascades, which, as I mentioned, is a not-for-profit funded by our federal government, Environment and Climate Change Canada. We hope that by the end of this presentation, we'll have discussed the environmental impact of inhaler therapies, identify 3 ways, or at least 3 ways, you can decrease the carbon footprint of your inhaler-based practice, and we'll show you some climate conscious prescribing tools that we hope you can start using as soon as today or tomorrow. Unfortunately, we are in a climate crisis, and this is beyond the scope of this presentation, but we just want to highlight that this crisis does have profound health impacts, and both on mental and physical health, but also related to the health system. We've got impacts on the supply chain. Here in the top left corner, you'll see a photo of one of our major Trans-Canada highways being wiped out by severe flooding that had health impacts, on physical health and mental health, but also impacts on our major supply chain routes, loss of infrastructure. And then obviously the extreme heat events. Australia, I know, has been hard hit by extreme heat and bushfires, and we've been experiencing similar issues here in Canada. We need, as a health system, to redirect precious resources for climate change adaptation and preparation.
On one hand, we're really struggling having to deal with the downstream complications of climate change, but on the other hand, we are in part responsible. We know that in Australia, 7% of greenhouse gas emissions are related directly to the delivery of healthcare, and about a fifth of these emissions are related to medications. Among medications, inhalers deserve special mention. There are many different types of inhalers, but the meter-dose inhalers, the ones that are shaped like the letter L, contain a canister that is full of hydrofluoroalkane, which is a potent greenhouse gas. Each canister has the equivalent greenhouse gas emissions of a car driving up to 139 kilometers. This is on an individual inhaler level, but if you take it at a systemic level, and what you'll see on the slide here is a pie chart detailing the carbon footprint emissions of the national health systems of the UK. The box in red identifies that 5% of the entire National Health Service's greenhouse gas emissions are related directly to both anesthetic gases and meter-dose inhalers. About 3.5% is meter-dose inhalers exclusively. If you put this in context, this is 3.5% of lighting, heating, powering every building, every medication, every IV pump, every item of garbage that's created. 3.5% of that is exclusive meter-dose inhalers. But the good news is there is a lot that we can do both on an individual and also systemic level. What you'll see here is the climate conscious sustainability pathway that was developed by Cascades, and it's a 4-step approach to decarbonizing the inhaler prescribing in your practice. We start off with the need to decarbonize, or does my patient actually need an inhaler? In Canada, we know that a third of patients that are objectively labeled with asthma don't have asthma on objective testing. We also know that 80% of patients who have negative asthma testing remain on inhalers despite this. Part of this is the need to manage expectations. So we know that the average post-viral cough lasts 3 weeks, give or take, but the patient's expectation is that coughing should only last around 1 week. So when somebody visits you in the office 2 to 3 weeks later and say, I'm still coughing, this is my asthma acting up, it's probably just a post-viral cough, and that's how long coughing should last for. Whenever we assign a diagnosis of asthma and treat asthma when there is no asthma, it leads to significant harm. In addition to the climate impact, we can miss an alternate diagnosis, severe allergies maybe, or heart failure. We risk identifying and labeling someone with a sick role, which has financial implications both in terms of insurability, also in terms of financial cost of medications and drug side effects. In Canada, this is such a topical issue right now that our Choosing Wisely campaign, which focuses on limiting low-value tests and low-value care, has issued not 1, but 2 recommendations not to initiate any long-term maintenance inhalers in patients with suspected asthma or COPD, adults of course, unless we have objective documentation of disease or airway obstruction. Once we've identified that somebody does need an inhaler objectively, the next step is to figure out which inhaler do they actually need or what type of inhaler we prescribe. This is going to focus on a few key questions. One of them is, are they getting the right drug class? Are they getting the right dose? Is the mechanism correct for them? Are they okay with changing their inhaler, and can they actually afford what you want to prescribe? The next slide illustrates a chart for asthma control lifted from our Canadian Thoracic Society guidelines on asthma management. When someone comes in requesting a refill for their short-acting bronchodilator, one of the first questions I ask them is this asthma well controlled? And if they're coming in for a lot of refills, the answer isn't necessarily re-prescribe their short-acting bronchodilator. The answer is often increase their steroid because they need to have better asthma management. Once you've determined the type of inhaler someone needs, we need to talk about the device, and there's a number of considerations here. Certainly carbon emissions are one, but you also want to make sure that some of our elderly patients have arthritis or neuromuscular weakness and have difficulty managing the different types of inhalers, and you need to try one, try the other to make sure that what they're actually having is sufficient. Age is also an important consideration. So a lot of the recommendations we're making here are for adults, and we do know that different inhalers have different cutoffs. Children, specifically those under 6, even those who are a little bit older, often don't have the complex coordination to take a deep breath in. We know that if you successfully switch even a single patient's inhaled corticosteroid and meter dose inhaler from a meter dose inhaler to a dry powder inhaler, this results in a carbon savings of 425 kilos of CO2 a year, which is equivalent to having that person go on a completely plant-based diet. And I don't know how many people you've successfully talked into veganism for climate change reasons, but I certainly haven't had any luck. Europe is way ahead of us. So if you look at the right-hand side of this chart, you can see that the UK prescribes about 88 to 90% meter dose inhalers. But if you look at the left-hand side, we know that Northern European countries like Sweden and Denmark prescribe about 88 to 90% dry powder inhalers. And here's the interesting part. They have the same rates of asthma, the same rates of severe asthma, same rates of admission, intubation, but they're able to provide equivalent care at a much lower carbon cost, and that's what we should be striving for.
Now, we hope that we've been providing a good case for why you might want to consider switching inhalers for your patients. So as Val already touched on, we really want to include the patient in this decision if we are going to switch. Although healthcare providers may feel like switching to a lower carbon option might be entirely the obvious choice, it is paramount that the patients are included in this decision before it's made, sharing the available options for them and the various factors for consideration. When a decision to switch inhalers is made without the patient's involvement and consent, we lose trust. And there are a number of ripple effects, but one of them would be the higher risk of non-adherence to therapy and thus worse health outcomes. There are a number of different factors related to manual dexterity and even lactose content of some of the dry powder inhalers that we want to include the patients before we make that decision. We often hear concerns about cost and these cost differences between inhaler options. And obviously cost can be a major barrier for some patients, and we need to consider that. However, given that different inhalers contain a different number of actuations and thus a varying number of days of therapy per device, we really encourage people to consider the cost per day or the cost per month for each inhaler option, as opposed to looking simply at the cost per device. Often we find that the lower carbon option is actually the same price or sometimes less expensive than a meter dose inhaler containing the medication of the same class. And you can see this on the right-hand side in the red box. You'll see that, for instance, budesonide dry powder inhaler, this is based on Australian data, that the budesonide dry powder inhaler is in fact cheaper per month compared to a meter dose inhaler medication. The next step in the pathway is to ensure that a patient is using the correct inhaler technique. So whether that's training a patient newly starting on an inhaler device, as well as regularly assessing patients to kind of check in on their technique over time. Unfortunately, we know that in many cases, the majority of patients are actually using their devices incorrectly. The numbers are quite staggering related to poor inhaler technique. If patients aren't using their inhaler correctly, they're not getting the most benefit from their medication, and that can lead to worse health outcomes as well as inhaler waste. So we really encourage you to familiarize yourself with the different devices that are available on the market. And we are fortunate that both in Canada with our Canadian Lung Association, but also with the National Asthma Council from Australia, we're thrilled to find that you have a fantastic resource with a number of very user-friendly, patient-friendly videos to help patients learn how to use their devices correctly. If you don't feel comfortable, depending on what your practice is, educating patients, specifically write on that prescription for a community pharmacist to review the inhaler technique with the patient, although that should already be part of their practice. Lastly, in the sustainable pathway relates to inhaler disposal. Many people are not aware that inhalers require special disposal practices. Unfortunately, you cannot just chuck these medications into the bin. This slide shows on the right-hand side 4 large bars identifying the significant carbon emissions associated with meter dose inhalers relative to the 8 smaller bars on the left. You'll see that in green, this relates to the carbon emissions associated with the use phase, The blue is the manufacturing phase, and the purple is the end of life phase. So after that inhaler has been finished, you'll see that a third of inhaler admissions are actually related to the end of life phase. Unfortunately, residual propellant can slowly leak out, further exacerbating their climate emissions and carbon impacts. And so best practice is that these inhalers should be incinerated, brought back to a pharmacy for that safe disposal.
Setting ourselves up for success. In addition to the tool that we've already described, there's an entire playbook in terms of decarbonizing outpatient care. This is available on the Cascades website, and it is hyperlinked in the slides. The resources available are divided into 4 separate sections: patient communication, provider education, prescribing tools, and then EMR searches, the latter of which is really Canadian specific. We've already went through the Sustainable Inhaler Pathway, which is one of the key resources on this website, but there's also a number of patient-facing tools. You'll find here an example of a chart that, a poster that can be presented either in your office or emailed to patients. These were developed using expert consensus and patient partners to develop materials for both education and spreading this message. You'll see here a chart of sustainable inhaler alternatives. On the left-hand side, you'll find a number of higher carbon equivalents. On the right-hand side, a number of low carbon equivalents within the same prescribing class, which in Canada serves as a quick reference if you want to switch someone from a higher to a lower carbon options, provided that you've had that discussion with them, of course. Although changing your prescribing practice individually is important, as healthcare providers, we're extremely powerful and we have so much leverage at the systemic level. So we were lucky enough to be able to contribute to the Canadian guidelines, or in this case, the British Columbia guidelines. This is a province on the western side of Canada. And we're happy to say this is the first set of guidelines in Canada that has an environmental impact section. It now goes through how to mitigate climate change in terms of decarbonizing your prescribing practice, but also climate change adaptation in preparing patients with asthma and COPD for forest fire season, which is unfortunately a yearly thing for us now. Thank you so much for having us today. I'm going to leave you with the words of Dr. Seuss. Unless someone like you cares a whole awful lot, nothing is ever going to get better. It's not. You're welcome to access all the resources available on the cascadescanada.ca website, and please feel free to reach out to both Dr. Cully and I. We'd be happy to hear from you. Thank you.
Thank you so much, Val and Celia. And now to sort of take a step back and look at the medicine supply chain, sort of from start to finish. And I'm joined by 2 brilliant guests, Dr. Eugenie Kayak from Doctors for the Environment Australia and Grace Wong, pharmacist for the Environment Australia. Welcome, Eugenie and Grace.
Thank you. It's a pleasure to be here.
Thank you.
Grace, I might start with you. What do people not realise as part of the medicine's manufacturing process and its impact on the environment?
I think there's a lot of hidden processes, I guess, in the manufacturing chain that the person, the average consumer, may not see or consider. When we think about pharmaceuticals, some of them are grown. First of all, there's the farming aspect, then there's the transportation, and then there's the actual manufacturing process. And then there's the packaging, transportation to the supplier perhaps. It might even be transported several times before it actually reaches the end user. So I think there's a lot of, I guess, steps in this process that can have quite a significant impact. And also because there's not as much awareness about some of these aspects, and we're only really beginning to understand some of the impacts, that there are measurable impacts and that there are people doing studies, I guess, to highlight these areas that I think then there is a lot of room, I guess, for improvement in how people can understand this.
And Eugenie, how about from sort of the part of the process where the doctor comes into it?
Well, I think one of the first things is most people, doctors included, are probably not aware of the significant carbon footprint of our medicines. Like, each individual medicine is quite small, but in Australia, carbon footprinting suggests that pharmaceuticals, PBS and non-PBS supplied ones, are over 20% of our whole healthcare carbon footprint. when you take into consideration our anaesthetic gases as well. So medicines themselves are a significant part of healthcare's carbon footprint. Healthcare has a significant carbon footprint, and then we're learning more and more about how specific medicines might have a higher carbon footprint than others, and some of these have very real good clinical alternatives that often practitioners aren't aware of, so they're not even factoring that in when they're doing their prescribing or choosing what medicine they might use.
And of course, carbon footprint is a big part of it, but it's not the only part of it, Eugenie.
No, absolutely not. So there's the whole environmental footprint of our medicines. Often we're looking at the carbon footprint because obviously we've got a climate crisis at the moment, and addressing the carbon footprint can also help us address waste, because it's about providing the right care at the right time, the right prescriptions at the right time. But our medicines, by their very nature, can impact our environment, our waterways, and therefore also our health. So there are a lot of factors when it comes to stewardship, environmental stewardship of medicines.
I can see you nodding there, Grace. Do you want to add something there?
Yeah, no, I completely agree with what's been said. It's such a broad topic to be discussing in such a short amount of time today, and the impacts, it's as Jeannie's highlighted, we're really beginning to understand the significant impact beyond the carbon. And I think that's really great today that we've got this opportunity to have a bit of a chat about it.
Well, let's talk about the medicine waste side of things. It's obviously a really big problem, like you say, probably not one we're going to solve in half an hour. But what is the low-hanging fruit in terms of things that we could start doing to make a big difference now? Grace?
Yeah, yep. I think there is so much potential for everyone to be involved. It's really about opening the eyes and asking the questions, whether that's directly in your own workplace, so beginning from where you are, just noticing the processes that are occurring around you, and then asking questions of your colleagues, or maybe it's the supplier, or maybe it's asking the cleaning staff, what are they doing with X or Y? I think there's a lot of potential low-hanging fruit to tap into. It in terms of specifics, I think it really does depend on your own workplace. But a very obvious one is obviously waste, because people are confronted by it. So that often is a place people like to start. But taking also a step back from that, how can we actually even reduce the amount coming in the first place? Where does it come from? What materials are they? Who's controlling what coming into your clinic or maybe your health service? So there's really an endless opportunity here. Maybe it will be helpful to have someone driving this to coordinate that effort, but it really just starts with that first individual to reach out and start asking the questions.
I do want to get into sort of structural differences and what could be done there to make that better. But coming to you, Eugenie, on this idea of reducing waste, it's something that you've looked at both in your own practice as an anaesthetist and also in your research.
Yes, thank you. And I guess I'll speak, yes, sort of in the anaesthetic domain then. And part of what we need to do, and what we haven't been doing but are increasingly doing in Australia and globally, is actually measuring carbon footprints and environmental impacts, so we know and can actually identify where action is required or where the hotspots are. And we might be surprised. For instance, if we look at nitrous oxide, which is a potent greenhouse gas, about 270 times higher global warming potential than CO2. So there's been increasing calls for decreasing the use of nitrous oxide, which is quite acceptable in certain scenarios. But then when people have done further research, they're finding that in many of our hospitals, and probably almost all of the ones where they have looked, about more than 70% of nitrous oxide is actually being leaked to the atmosphere through infrastructure. So through the manifolds and the piping within our hospitals, because nitrous oxide is odourless and colourless and not very expensive, health facilities when they're looking, are finding significant leaks which far outweigh the carbon footprint of potentially any changes in your clinical practice. So that's just one example of when we start actually measuring and looking a bit in a bit more detail, where we might find some really good wins when it comes to decreasing carbon footprint.
Right, so the assumption of what you think the intervention isn't necessarily what it is. That's the reason we need to be looking at this so closely.
Absolutely. And if I just could give another example, and I think you might have Forbes McGain has spoken as well, but when he looked, studied morphine, 90% of morphine's carbon footprint was from the packaging and the sterilising when it came to intravenous morphine. So it may not always be the medication, which can be quite alarming, but at the same time I think, well, that's actually fantastic in a way, because surely we can address the packaging and the energy sources of how it is being sterilised far more simply than actually addressing how the compound is being made and that carbon footprint. So I think by investigating in more detail, it actually produces a lot of opportunities to actually provide more sustainable healthcare.
Grace, are there any really salient examples from your work that you'd mention?
Actually, Forbes came to mind because I'm fortunate to work with Forbes at my health service, and just actually really enjoyed listening to Eugenie there, to really highlighting the opportunities, and it just made me reflect on in my own workplace that often we might start initiatives or someone has an idea, but it often the end result is perhaps not what we expect. But there are so many gains from that exercise or that idea that then people are empowered, that individual or individuals are empowered to then do other things and take on other activities. And also it opens up a lot of doors and questions about, oh, what else can we do? I think that's why it's really important to start that conversation. Because it's not really exactly about, right, we need to have a goal in mind to reduce something, reduce X, reduce Y, but to also realise that there are benefits much beyond just that focus, if that makes sense.
Absolutely. Now, in the lead up to today and then also throughout today, people have been asking their questions, and a question from the audience that feels really salient here is, as a nation, how can we collectively manage pharmaceutical waste, for example, blister packs, recycling, rather than it being up to individual organisations?
I might just talk generally, and I think maybe Grace can talk about the recycling. But part of it is actually starting at the beginning, isn't it? And it's actually looking at our prescribing and prevention. So actually decreasing the amount of medicines that patients are required to have. And I think polypharmacy is becoming a real issue. So yes, more and more patients are coming in with bigger and bigger blister packs. So actually the actual amount of blister packs should be addressed by providing better healthcare. As far as recycling blister packs, recycling is really complicated, and it varies not only between states but also between jurisdictions within states. And it would be fantastic to have some national guidelines, and there is a national unit that's being set up at the moment, a national health, climate and sustainability unit. And I guess many of us are hopeful that that unit will be able to install some overall guidelines. So some of these really quite tricky problems can be done in a coordinated manner. But Grace probably has more to answer on the blister packs.
Yeah, no, thanks Eugenie, thanks Tegan. I definitely agree with all the points being raised. Going back to that original set of what is actually going in is really important. But if we are looking at, well, okay, we're left with this waste. In terms of blister packaging recycling, there are already organisations that are offering this service. It does come as a cost. So I think cost has been a bit of a barrier, and also it's not coordinated. So individual organisations or companies can sign up at the cost, and then have their product taken away, the blister packs, that is, the empty blister packs taken away for recycling. It is quite complex because they're still very small scale, my understanding is, in Australia in terms of the recycling aspect. And, looking at also, are there opportunities to even make these blister packs in other materials? There's a lot of questions about why this is happening. Why are we accumulating this? And again, it goes back to the original question, how the input coming in. I know in Europe, they're looking at biodegradable blister packaging, and blister packaging that has plastic on one side, that's soft plastic so you can see the tablet, and the foil underneath. I mean, if it was just foil on both sides, which some packaging is, that can be scrunched up and probably a little bit easier to manage compared to composite materials. So I think there's a lot of questions here, probably more questions than answers. And in terms of a national approach, definitely having a national body, as Eugenie's highlighted, is a very promising opportunity. I think regulators such as the TGA also potentially have a role in this, because they are the gatekeepers to our medications and medical devices coming into Australia. So to what extent we then look at the layers of regulation that can help manage what is coming into Australia and what requirements we need so that these materials can be recycled as well.
It was originally part of the plan for this panel was to have someone from industry as part of this conversation. It's a real shame that we're not able to sort of put some of these questions to them or allow them to explain what they are doing. So if you've got questions along those veins, do put them in the Q&A chat and we'll do our best to answer them later in the day or after the conference itself. But another question from the audience that sort of speaks to what you were just saying before, Grace, is how can health and medical services push pharmaceutical manufacturers and suppliers to improve and verify their sustainability commitments?
Yeah, it's a really, really important question. So thanks for the person who asked that, because there is so much opportunity, but it's finding out who you need to speak to and making that step to speak to that person and being persistent. I mean, in terms of the pharmaceutical supply chain in Australia, we have manufacturing, but we also have the supplier, the middle person, and then we have the pharmacies that are receiving it, and then we've got the distribution within health services and other organisations. So there's a lot of steps here. In terms of suppliers and manufacturers, I think there's a lot of advocacy opportunities here. One is directly with your supplier. I mean, if you're a pharmacy and you are having a contract, a significant contract when you're a health service with a supplier, you actually have a lot of power, opportunity there to negotiate. There are contracts. These things can be written as weighted criteria into contracts. And potentially even writing things such as getting the suppliers to assist with funding, to get initiatives going, to help with closing the loop. I think there's a lot of work that can be done there. In terms of pharmaceutical manufacturers, sometimes they're a little bit tricky because they're one step removed from a pharmacy point of view because we've got the supplier in between. But again, I think a lot of opportunity because it's about the connection with them, speaking with them and highlighting what the concerns are. And I think for states, in particular states that do purchase as a state, so they have a lot of a bit more buying power, I guess, there's a lot more opportunity there to do some negotiation again at that higher level to ask for what is required and to put that in writing. Some of this, I guess, sounds very idealistic, I know, but I have seen it in practice. It does work if people are persistent, and it's small steps. It may be just one medication that you start with. It's not the whole contract for the 40,000 lines that the health service has, but it may be that one item that is a high mover, or maybe it's the one that then starts the ball rolling. So I think there's really a lot of opportunity there by starting the conversation and finding out, well, who am I actually even meant to be speaking to? Who is controlling the strings here?
Eugenie?
I'll just add a few to that. I think Grace is right. We have to be speaking up. We need to educate ourselves. We're in the healthcare profession, and this matters. And we will be listened to eventually. And it's about speaking directly with our suppliers, but also advocacy, I would say, at a higher level. A lot of these pharmaceutical companies, they're big multinational companies, so they're also having pressure from England's NHS and even in America now and in Europe to have environmental stewardship plans and emission reduction targets. So we shouldn't be just accepting what they're telling us. We should be asking for evidence, particularly when it comes to new products. We need to ensure that technology creep is actually also taking environmental considerations into play, but also that it's evidence-based. So when companies are coming along, and it might not just be medications, it might be technologies as well, and saying this is the new thing, this is much better, we need to be asking for the evidence. Companies are coming and saying we've done life cycle assessments, this has a lower carbon footprint. Well, we need to be asking for the evidence and ensuring those life cycle assessments are done to a proper standard, because that's also an issue that is creeping in. The NHS, as speakers before may well have said, they have 80,000 suppliers, and they have sort of demanded that their suppliers by the end of the decade meet or beat their emission reduction targets. Collectively, healthcare as a whole can be very powerful in influencing industry. And I think, as is often said, industry don't mind change if they've got definitive targets, if they know where they're going as far as making changes. And if I can just add one more thing there, some industries are now signing up to the science-based targets, so they are actually making commitments, like AstraZeneca and Novartis as examples, and making emission reduction targets and commitments for their value added chains. So that's really pleasing. And if those big companies can do it, then I've got a bit of hope there.
A lot of this conversation and throughout the day has been very much about like people's spheres of influence. You know, what can I do as an individual doctor or pharmacist or someone else in the healthcare system and influence that sphere, which is really lovely. But what about structural change? What about national leadership, like you alluded to before? Because that's what's actually going to really move the needle. Grace?
Yeah, it's a really important aspect, isn't it? And I guess today we've got Dr. Eugenie here from Doctors for the Environment Australia, and I'm a big admirer of their organisation, because they are a national advocacy and organisation. And people like that, individuals like Eugenie and also her colleagues in her organisation, are really leading the way for those type of discussions, as you mentioned, that need to be at a higher level. I think there is movement in governments and in some regulatory bodies, at least at a state level. I know I'm based in Victoria, and there is some movement there, and I think that there is some movement, but it needs a bit of a push from organisations, and also from organisations that represent health professionals, for them to be on board and to really be more active in their role. So, I mean, it's one thing to sign up for something, for a statement, but the next step is for them to also take an advocacy role. So each of the professions and their professional bodies, I guess, as well.
Eugenie?
So obviously addressing healthcare sustainability, and that includes medicines, is a bottom-up approach and also a top-down approach. And as medical professionals, healthcare professionals, pharmacists, we have a lot of agency in this space and more influence than I think we sometimes appreciate. Influence to educate ourselves, our professional bodies, the public, and policy makers. In 2023 in Australia, it's actually a fantastic time to be in this space because a lot is happening. As I mentioned, there's the national unit that is being formed or has been formed in the last year and is about to release in November a National Climate and Health Strategy. But also the Australian Commission for Safety and Quality in Healthcare has a sustainability in healthcare module that went under extensive consultation and is coming out hopefully by the end of the year. So there are those levers that I'm really hopeful will initiate considerable change and also elevate awareness of the change that we need. Another thing that, if I could just mention, the AMC, so the Australian Medical Council, that actually oversees education of medical students, junior doctors and specialists, are beginning to put sustainability in healthcare principles and climate change health risk into education requirements. And that's happening this year and next year. So that, again, is very positive, I think, because it means from a very young or early age, healthcare professionals should be learning the basic concepts of sustainability in healthcare.
Well, if the attendance at this conference is anything to go by, there's definitely an appetite for more discussions about this. And we have been receiving questions, as I said. Someone's come in, I might put this question to you, Grace, asking what policies are currently in place that support sustainable use in medicines, and what policies need to be put in place?
Yep. Well, certainly we do have some medicine policies already in place to help the appropriate use of medicines. I mean, everyone here is probably familiar with the PBS. The PBS does have some restrictions and limits on quantities and indications to help guide clinicians in the appropriate use of medicines. And I believe that really supports then also sustainable use. QM stewardship in health services, in also primary care settings, is also a big driver in encouraging appropriate use of medicines. And I think it's been mentioned earlier in our chat, the review of medicines, both by any clinician, whether it's the doctor or pharmacist, informally or formally through medication reviews, to reduce that polypharmacy load. These policies, but also these services, I guess, are already available. There is also a lot of room, I think, for more to be done, and I think it's already been alluded to by Eugenie through some of the national bodies that have been developed, that I'm very hopeful that then can help guide some more concrete strategies and policies for Australia as well. But certainly there are a few things already that people can tap into.
Eugenie, is there anything you'd add to that?
Just re-emphasising that the appropriate prescribing is so fundamental, and that is obviously prescribing the right drug at the right time and ensuring that it is used appropriately. And with prescribing, is it twice a day, 4 times a day? Can we actually look at the carbon footprint of the medications that are actually being prescribed? And does the PBS have a place in how they restrict or not medications? For instance, meter-dosed inhalers, the one dry powder inhaler that is a short-acting beta agonist is PBS restricted at the moment, whereas salbutamol, which has a much higher carbon footprint, isn't. It can be actually purchased over the counter. Also from, I guess, my profession in anaesthetics, there's some of our anaesthetic gases are far more carbon polluting than others. For instance, desflurane has a carbon footprint with clinical practice about 20 to 30 times the clinical alternative. Western Australia Health have literally just come out a month ago and been the first state in Australia that's actually banning desflurane from the public hospital formulary. There's been a lot of advocacy that's gone on behind that for many years, and that's fantastic, and we're really hoping that other states will follow. They're not outliers there by any stage, because the NHS is already planning to ban it next year, and the European Union are looking at decommissioning it in desflurane in 2025. So there are regulatory levers that can be utilised.
Just briefly to close, we've talked a lot about this fact that there's a really big, long life cycle in medicines, all the way from sort of farming, manufacturing, distribution, and prescribing, and then waste. If there's sort of one chapter of this life cycle that we could be focusing on to get the best environmental impact in a good way, where would that be, Grace? Just a little easy one to finish for you.
It's an easy question. I mean, when we look back to the study on morphine that was mentioned earlier, it really highlighted packaging as and that final sterilisation phase. And I find that really fascinating, because when we look around at medications, packaging is, and advertising and how the packaging is created is, for me as a pharmacist, there's a lot of opportunity for change. When I see hard plastic bottles then inside a cardboard box, and then then there's all this glitzy stuff attached to it. There's a lot of things that in the packaging side really interest me, because I think there's some very easy fixes there, if the right suggestions, I guess, and regulations were made for the manufacturers. So for me, although I think the whole process, that there are a lot of opportunities for change, that part has always fascinated me, because it's so also confronting. And a lot of my colleagues, that's often what they first mention is, the packaging, the waste that we're confronted by on a daily basis. So I would love to have more opportunity there to make some change, to visually make an impact, but also to then inspire other people who may also be feeling that confrontation, to then look deeper to see what other parts of that chain that you've mentioned can also have some improvements.
We are nearly out of time, but Eugenie, anything you'd add there?
My quick last thought is that we really need to focus on practicing good medicine, so high quality medicine, because if we're prescribing and delivering the right medicine at the right time, and if it's being used appropriately, then we are going to have less waste. So I think that is fundamental from addressing healthcare and the carbon footprint of medicines as well. And there are many opportunities to do that a lot better. Thank you.
It's absolutely been a thread so far today, and I'm sure it's going to continue. Eugenie, Grace, thank you so much for sharing your expertise.
Thank you.
Thank you.
Well, how about some resources to help us actually implement this? I'm joined by James Catty, who is the Manager Environmental Sustainability Standards at the Australian Commission on Safety and Quality in Healthcare, to discuss the environmental sustainability and climate resilience healthcare module that's currently in development. James, tell us about the module.
It's a mouthful for a title.
I stumbled over it.
That's okay. So the module is really a framework of actions for health services. So we worked with a group of technical experts, clinicians and consumers to come up with high priority areas where health services can guide their actions. So we're looking at high impact, top down, but also bottom up. So everyone needs to be involved in the game. The module guides actions for health services in terms of addressing climate resilience, so making sure that their services are going to work in the future for a worse climate, but also reducing the impact, because we know that the impact of carbon and emissions on healthcare and on the environment through healthcare is really important to address. So it's taking those approaches and putting a framework so that those actions can be used.
What's the timing around the module?
So we've gone out to public consultation early last year. We got a really good amount of feedback. We had something like 96% of people saying we're really interested in this, and the remaining 4% were, we need resources. We need to be able to know how to do this. So on board, but how? So what we're going to be doing in the next couple of weeks is publishing the draft module for people to be able to look at and see. and working towards a pilot of the module. So working with health services, ones that are advanced, that have done a lot of work, and also the ones that are struggling to figure out what actions they can do reasonably within their means to help achieve the whole healthcare system going across.
It's interesting you mentioned that, because we have obviously been asking for questions from the audience, and one person has written in asking about small remote hospitals, what kind of sustainability practices might be recommended there, and what's the kind of cost associated with these more sustainable practices?
Yeah, I think it's really, it's an often forgotten area of the healthcare sector, but they're equally as important. So 2 things come to mind. One of them is those sort of more regional areas need to be working with the people that are in those regional areas to come up with solutions that are going to be climate resilient. So we've heard from people in WA who are doing that with local and First Nations people in trying to deal with heat. It's inevitable. The second thing about cost, I think that there's an interesting two-side to that one. There's a cost of doing something and looking at an attractive, smaller cost per item, but you add procurement, you add waste fees on top of that, and that actually blows out. And then there's also a cost to not doing anything. So I think that that's a really important balance to look at. Some activities will have a high overhead, but also some of them have got a really good gain back for the healthcare service as well, that they can reinvest that to treat their patients.
Another question we've got is, are there options, sort of looking at kind of what kind of levers we have at our disposal, are there options to embed the federal climate target into the Australian healthcare sector? Is it possible that we might see something like codes of practice or legislations requiring sustainability?
Yeah, so I think we heard from Paul Kelly earlier from the Australian Government Department of Health and Aged Care with the National Health and Climate Strategy, which is a great piece of work. We're really excited to be working with them. So the module fits in with that strategy. I think that in advance of those sorts of legislation levers, it's important to realise that there's an urgency to some of this. In addition to the fact that a lot of clinicians and health services are doing sustainable healthcare, they're providing appropriate and safe care that is sustainable healthcare. So, and partnering with consumers for climate resilience, another way that, we're working towards that already. So it's just highlighting those high impact areas that health services can focus on to get a great effect.
Yeah, and then lastly, what are the best resources that we can access on this topic, including up-to-date information and evidence? That is an actual question that someone sent in, but it feels like a real Dorothy Dixer for you.
So evidence is always really important. The Commission is looking at trying to work with its advisory group to locate those resources, bring them together and really sort of direct them, these resources will help you meet these actions in our module, those framework of actions for health services. So a lot of really good work has come out of Australia and internationally as well. So we're looking to use what's already been done and really working together to try to make sure that everyone knows what their responsibility is and their opportunity is to providing safer and high quality care, as well as being sustainable.
James, thanks so much.
Not a problem.
It is time for us to take another short break. Go make yourself a cup of tea, and then we'll be back soon with session 4, Thinking Differently.